Good evening. Welcome, ladies and gentlemen, to the London School of Economics and Political Science and to our online event on vaccination strategies. My name is Piroska Nagy Mohácsi, and I am the interim director of the Institute of Global Affairs at the School of the LSE and the School of Public Policy. We are very pleased to have a global audience with us today, and on a subject that is truly topical, one of the hottest topics today. As the economists like to put it, this is a frontier issue. It's really at the frontier of knowledge and inquiry, vaccination strategies. This webinar is under our Marion Forum initiative. It's about transformational leadership. And we believe that the way governments have prepared for and are addressing the vaccination issue nationally, regionally, and globally is a true testament of their efficacy and overall credibility and readiness. So this is really a topic for leadership issues as well. So here we are. In less than a year, humanity has produced half a dozen approved effective vaccines without any scientific shortcuts. This has been nothing short of a miracle and a testament to human ingenuity really, and global collaboration with a very healthy competition along the way. In and of itself, we're going to do a seminar on this because we can learn a lot about how to best cooperate and compete at the same time at the global level. Now, how important this achievement that we have these vaccines today is so clear now that the virus has mutated, that it has become, some variants have become more contagious and possibly more deadly. So vaccination and having the vaccines, potent vaccines, is really critical for winning the race against the virus. To date, some 55 countries has started to administer vaccines, although the process often painfully feels very slow. But some countries have fared very well. Israel leads the world by having vaccinated around 30% of its population. The United Emirates and United Kingdom follows. The latter have vaccinated 8% of this population. We will hear about these experiences, learning from learning good lessons, and we will discuss important topics such as vaccination supply, its distribution, vaccination efficacy, global access to vaccines, and so on. We will hear about country experiences and these subjects. We are truly honored, truly honored to have today an exceptional panel. We have outstanding experts who really devote time for us to learn from them and listen to their assessment and guidance. They've taken time from their probably several day job that they have to perform in addition to being an academic. They advise governments, they participate in national and global efforts to deliver the vaccine efficiently. We have these three papers. First, we will hear from Professor Rand Balicer, who is the founding director of the Clalit Research Institute and the Chief Innovation Officer, Direction of Innovation Division at the Clalit Health Services, which is Israel's largest healthcare organization. Last year, Professor Balicer was appointed as chair of Israel's National Experts Panel on COVID-19 and serves as a senior advisor to the Israeli government and the Prime Minister on COVID-related issues. Professor Balicer is also a tenured professor at the Public Health Department of the Ben-Gurion University. Then next, we will hear from Professor Prashant Yadav. Professor Yadav is a senior fellow at the Center for Global Development in Washington, D.C., USA. He is an affiliate professor at INSEAD as well in France and a lecturer at Harvard Medical School. Professor Javad is a globally recognized scholar in the area of healthcare supply chains and author of many peer-reviewed scientific publications. And last but not least, we will hear our very own professor from the Department of Health Policy of the London School of Economics, Professor Olivier Waters. He is, in addition to being a professor at the department, he's also co-director of the master's program of global health policy, for which I'm sure there's a lot of demand these days. Professor Waters' research focuses pricing and affordability of pharmaceuticals in various regions, and he has published widely in this subject and others. Just before starting, very few housekeeping matters. Number one, please submit your questions, and for that use the Q&A feature at the bottom of your screen, although honestly on my screen it's at the top, so find it please, and submit your questions. I will take the questions and will pose them to our speakers, as many as I can, and I will try to group them as well if needed. Please keep the questions brief and possibly include your name and affiliation. For Twitter users in the audience, the hashtag is #LSE vaccine, one word. This is an online event, is being recorded, and we hope to release it as soon as we get the approval of our speakers. But now enough of the introduction. We are delighted to have you, Professor Vaz, here with us. The floor is yours for the presentation.
Thank you kindly for this very generous introduction. It is a pleasure and a privilege to be here with you today. And I hope that some of the lessons learned and the messages coming out of Israel will be of some use to other countries which face the same dilemmas and the same challenges as we do. And I hope this would be in any way helpful. So we will look at the Israeli case study and what we can learn from that. So with no further ado. I will start by saying that Israel is in a pretty dire condition in terms of where we're standing in terms of COVID, putting COVID in check. Right now, we have the highest level of COVID infections that we've seen since the beginning of the pandemic. It is exceedingly difficult to contain it despite a prolonged lockdown that has been ongoing for 3 weeks now, and even more with partial lockdowns. And as you can see, the daily number of cases per million in Israel is probably higher than almost any other country and has been so for the last few weeks. So this is a very fierce events that we're seeing. Also, we know that about 50% of the currently new infections are due to the B117 strain in Israel as well. This strain has been shown to be both more infective and probably also potentially more virulent. So this is a serious condition to be in. In terms of mortality, indeed, we have the highest mortality, again, that we've recorded since the beginning of the pandemic. And it doesn't seem like the numbers are going down just yet. And I will try to address here right now to explain why that is the case, despite the formidable vaccination campaign that has started a month ago. So where are we standing in terms of vaccination? The immunization rates in Israel, we have already provided 4 million doses. It's a country of less than 9 million people, and we have provided about 4 million doses. 2.7 million Israelis got their first dose, and quite a few also got 2 doses, and that is worthwhile mentioning. And if you see the graph in front of you, you can see the age distribution of what we have been able to achieve. 90% of the people between the age of 70 and 80 have been already covered and vaccinated with 1 dose. And you can see the sliding scale here by age of how the vaccination campaign went through. So before going into what allowed such a quick rollout and such high coverage, I want to first explain why, despite this campaign, we do not see any alleviation right now of the severe cases or the recorded cases. So if you'll take a look at this data in front of you here, you can see here the immunity among those age 60 and over in Israel. So despite the fact that I've shown you that over 80% of our population has been covered, when you ask the question, what percent of the over 60 have already gone to the point where they should see the full effect of the vaccine, the answer is only 22% of them until now. And actually, 50% of the elderly population are now only partially immunized. They have passed more than 14 days from their first dose and less than 7 days from their second dose, so they haven't seen the full effect of the vaccine yet. In the coming 2 weeks, more and more elderly will graduate this process and will get through their second dose of vaccine and will gain the full effect as hopefully as was seen in the clinical trial. And so when that will happen, when in 2 weeks' time, when about over 3/4 of our elderly population, this is the population where 92% of the mortality is witnessed, and where about almost 80% of the severe disease is witnessed, then we should see a decline, hopefully, in the severely ill patients, and this will be happening gradually, as we hope. And again, all the time in the background, there is the increase of the B.1.1.7 strain that might have higher virulence and might negate some of this helpful effect. So this is one point to make. I think it is quite important. And I will also mention that in a study that we've done that had a lot of attention, I know in different places, we have released some preliminary data to discuss that have shown what was the impact of the vaccines provided very early on, 14 days after the first vaccine. So we, just to go very briefly into that in a second, I will elucidate what that study had shown and put it into context. But before I go there, there's more depth that I want to go into in what have we learned from our vaccination campaign. So how come we have been able to cover as many people? I think that the first point is that Israel is a small country. It's only 9 million people. And that is really helpful because providing 4 million doses is a small dent in the international supply chain, but it is the meaningful impact in Israel. Having the same impact in larger countries would be much more difficult. Israel is also much more geographically condensed, which gives us an easier way of getting to a higher percentage of the population. So these are two structural issues that are beneficial. And so thus comparison to other countries, it's not really fair. To go above beyond that, we have universal health coverage, and 4 organizations take care of the entire population. They are very strong logistically. They're the sick funds or the HMOs. They are very strong logistically. They have a very centralized control of the entire workforce, and they can mobilize it in times of need. And times of need do come around. We are not unaccustomed to times of emergency, and we have an experience in quickly mobilizing large amount of our workforce into a all hands on deck situation. So this is helpful also in getting quickly geared up and rolling out in this vaccination campaign. So the logistics capacity of these organizations was very helpful. And one thing that also helped us was the fact that we did not do a very complicated prioritization scheme. We have decided very early to go very simply. We said 60 years and older and healthcare workers, that's it. And for several weeks, this was done. We had some other opinions that said, but you have all the data in the world. Why don't you try to focus on population at risk, people with chronic morbidity? We chose simplicity. And so this was something that was really important, and we tried to abide by that. It was also helpful that all of the Israeli healthcare system is very highly digitized. Everything is digitized. We have electronic health records for over 20 years, and we have a lot of digital health put into practice. And it was fairly straightforward for us to create appointment apps that were allowed people to schedule their vaccination queues, and people coming into the vaccination station, they give either their ID or their HMO card, and they're immediately put into the computer. We know that they came in, we know which vaccine they got, what batch, at what time. We can send them the invite for the second dose immediately, so they will have it in their schedules, and we can follow up on it. The fact that we have such an immediate access to all of our patients and records, it allows us also, we've been using call centers to call our elderly population that didn't deal well with digital health and the automatic processes. And so we still are calling individually the older population and asking them to come in, telling them where they can schedule their vaccination clinic. And I think that is also very helpful. Two more things that I want to mention in terms of what helped us in this vaccination campaign. One is the issue of agility. We are making great strides to make sure that no vaccine is being wasted. There's a very strict cold chain issue, and if you get the vaccine out of the freezer, you need to use it or lose it. And what we do is whenever the time comes and we see there are only a few hours left and we have some leftover doses that need to be provided, it's everybody in. Anybody who comes in near the clinic, we even have SMS messages and social media telling people there's leftover vaccines in this clinic, just come over and get the vaccine no matter what age group you're in or what priority group. And we didn't waste more than 0.1% of the vaccine vials that were opened until now, so that was helpful. Final point I want to make on the vaccination campaign before touching very briefly on the issue of the vaccine effectiveness studies is the fact that we had to fight a very serious problem of an infodemic of vaccine hesitancy because of fake news and because of misinformation and disinformation that was distributed in all communities, but more in some less disenfranchised communities, and it was a serious problem. So what we've done in order to deal with that is we took it as a very serious national task, and the first rule was transparency. We told things as they are. We went on TV, we said what we know and what we don't know. And the public got used to hearing from us when we say we're not sure, we say we're not sure. When we know something from the clinical trials, we say it is, and when we don't, we state it, and that helped create the to change the minds of some of the people that maybe perhaps were worried. Another thing that we did was have a lot of leaders come in on live TV, get the vaccine, and show that this is what they select for themselves and for their families. And we did a lot of culturally adapted messaging, trying to reach out for every sub-community, the ultra-Orthodox, the Arab Israelis, various languages, but also cultural approaches. So I myself went to one of the rabbinical clerics lessons that took place, and for 2.5 hours, they grilled me in questions about the trial and all of the fine print of the different clinical trials. And at the end of the process, the rabbinical leader said, I'm convinced, and a week later, he had a rabbinical verdict, says, this is a safe and effective vaccine, everybody come and use it. And so did chief rabbis and qadis and people, and that is exceedingly helpful because all of this is very local. I would like to my final points, beyond all of these lessons learned, some of the things we haven't sorted out yet are the issue of how do you vaccinate people who are bedridden and home-ridden, who cannot leave their house. Because there's a problem with the vaccines of both Pfizer and Moderna that they cannot be shaken and they cannot be moved around. What we've done was, first of all, to vaccinate some of the household members of those people who are bedridden and at risk, and also, very helpful, at some point, we really made great strides to put them in ambulances, ventilate them if needed, bring them to the vaccination clinic, vaccinate them there and bring them back. And so we've been able to vaccinate, I think, over 60% of the bedridden population by now, and still ongoing. My final note is going to be about vaccine effectiveness, and I will touch it very briefly. We have done a large-scale retrospective assessment of the vaccine effectiveness. And what we did was a retrospective cohort of de-identified data on all of the Clalit members, and we looked at there's a lot of methodological issues in real-world studies of vaccine effectiveness. I cannot go to all of them at once. I will also just mention that morbidity changes dramatically over time, and it's differential across groups. Vaccinated individuals vary different from the unvaccinated. And this difference is differential in different population subgroups and changes over time, just to add to the mix of the complexity. And I will tell you that in Israel, there's an inverse association between vaccination and morbidity. Places with a lot of vaccination have lower morbidity, and that's another confounder or bias we have to take into account. So the preliminary data that we've released, already more than 2 weeks old, was a comparison of 200,000 elderly above the age of 60 with over 11 days of follow-up then. It was like 1 million vaccinations ago, and 200,000 vaccinated matched group. And what we've looked at the PCR of the test positivity. These are asymptomatic as well as symptomatic. Therefore, it's very different from the clinical trials of Pfizer. And what we've been able to show was that there was no difference between the vaccinated and unvaccinated groups for 12 or 13 days. But then on day 14, the vaccinated group parted and a marked decline in the PCR positivity rates was witnessed. And it continued on for several days, and it reached about 33% reduction in the positivity rates. It probably would have continued longer, but at that time we didn't have much follow-up. And therefore, we were quite happy to see that the vaccine in real life does what it's supposed to do and what was seen in the Pfizer clinical trials. So that was very reassuring for us to see. Some people have wrongly interpreted this as saying that the vaccine can only reach an effectiveness of 33%. This is of course not true. This is what we've witnessed, the days 14 to approximately 17 or 18. One could only expect the vaccination effectiveness to continue to increase as time goes by, and depending on the way you do the calculation. We have a full-fledged large-scale study with a proper methodology in process right now, and the results of what is the actual vaccine effectiveness of the entire period following the first vaccine and more will be released there. We've decided not to do any more partial data because it was misinterpreted. So just to note again that the results, these are 60 years and older, not like Pfizer, 16 plus. These are asymptomatic and symptomatic illness, not just symptomatic as in Pfizer vaccine. And it's a short few days follow-up following the first dose, especially few days after the day 14 after the first dose. So with that, I will adjourn and I will later gladly entertain any question. Thank you for the opportunity to speak with you today, and I'm looking forward for the rest of the talks. Thank you so much.
Thank you so much, Professor Valitza. That was really a roller coaster, and also one felt the effort as you did it, and the important elements that you highlighted. And I think that we already can think of important lessons to be called upon. I don't want to keep up the flow of discussion. Let's move on. I would like to ask Professor Prashant Yadav to take the floor.
Thank you, Piroshka, and thanks everyone for joining us. I told Piroshka when she first asked me to join this event, I said, well, I will myself learn a lot from both Professor Balicer and from Professor Wouters, and so it will be a very worthy investment of time to learn from them. And what I heard from Ran just now corroborates that. I think we've been reading about some of the work in Israel, but hearing it firsthand from Ran was very illuminating. What I intend to do is share with you some core ideas that have emerged by looking at vaccination in countries which have done an early rollout. So just a cross-country comparison of key decisions, and these decisions are tactical and operational variables, so not things such as what population groups to prioritize, what vaccine to use, but things such as how to roll out the vaccine, how to distribute the doses, what structure of the distribution system to use. So very operational and tactical variables. And the claim I'll make is that these are the things which are impacting the rate at which countries are able to vaccinate. And I think, for example, here in the US, we see considerable variation from one state to another in the number of doses which are sitting in the freezer versus actually going as vaccines administered. So it remains unclear, what's causing that. So there are 5 key operational levers that I want to talk about. Again, this is an area where I see reasonable heterogeneity across the countries who have started early vaccine rollout. So US, UK, some countries in Europe, Israel, India, Indonesia, and some early data from Singapore. So first thing is that this is something we predominantly have seen in the US is unless we can reduce the variability in supply, and by variability in supply, I mean week to week, how much stock or how many doses are being sent to each vaccinational clinic relative to what they have asked or relative to what their population cohort is. If there is high variability in this, it leads to clinic staff trying to reserve more doses because they are worried that they may not get enough supplies in the future. And this is a combination of reducing variability, but also improving information and transparency about what is coming to a clinic in the next 5 days, in the next 2 weeks. And this kind of planning is not very hard to do, but it's largely about sharing advanced supply information. So that is something where we've seen considerable variation in what Israel has done, what India is doing, what we've seen in the United States, what we've seen in the plan in the UK, in Spain, and so on. In some countries, the clinics are receiving a very clear estimate of what will come to them in the next 5 days. And in other countries, they have almost opaque information. And when the box arrives, that's when they find out how many doses they got. So that's one key difference and a success factor as well. The second is something that Ron was talking about in Israel, which is having the digital infrastructure to do scheduling, pre-registration, being able to inform the populations where they can go to get a vaccine and when, and do some kind of advanced registration for it. And here what we've seen is that who makes this infrastructure available, whether it is the central government or it is a sub-national government level, so whether it is a canton or an autonomous region or a state, depending upon the governance structure in a country. But the key part here is that we've seen two types of digital infrastructure uses. One, which is being built the first time for COVID-19 vaccinations without having an underlying digital foundational layer. And the other is a type in which there is some foundational layer of digital infrastructure that exists and an app or something to schedule is being built on top of that. So starting from scratch hasn't worked well for many of the countries. Starting from something existing and building on that has worked better. The reasons remain unclear as to, is it because the uptake is weak? Is it because the design of the systems in such a short span of time doesn't work? Or is it about the interoperability and the connects between the scheduling system and the other systems that exist? The third, which has been a point of contention and debate across the countries, is how do you do prioritization and how do you actually operationally run the priority scheme? So one thing we've seen is that if the size of the priority tier is larger, what Rand called as simplistic rules. But in addition to simplistic, I would say if the number of people in a tier is larger, then the task of matching demand and supply becomes easier. Because even with the uncertainty in how many in a given tier are actually going to come to get vaccinated, even with that uncertainty, you are starting with a larger number of people in a given tier. So having a simple tier in that sense also helps on reducing demand uncertainty. And India has used 50 plus, Israel has used a 60 plus, very simple in that sense, but also larger in numbers. The other part in the prioritization is this idea that we've seen used in the US, in UK, at least initially, and now some of it is changing, is sequential prioritization and allocation. What that means is you have phase 1A, phase 1B, phase 2A, and these, and the way you then start allocating is to say, until I will achieve full coverage in phase 1A, or whosoever in phase 1A is willing, I will not start the phase 1B. When I finish phase 1B, then I'll sequentially move to phase 2A. And while prioritization is important, such sequential allocation of the priority tiers leads to higher opportunities of demand and supply mismatch occurring. Because if you had a given number of people from phase 1A that was scheduled to come at a clinic on a given day and a fewer came or more came, then the supply doesn't always match. So you have either a shortage or excessive doses, which then the healthcare professional has to allocate in an ad hoc manner to people outside the tier, and that creates some resentment in the population. So the easier way to fix this problem is to do what we call a simultaneous nested prioritization, which means you keep a total amount of stock in the clinic, and then within that you say some amount is kept for the highest priority patient population, some amount is, the remaining is kept for everybody as a common pool, and as patients or as vaccinees are arriving, you start allocating the doses from that pool till you hit a threshold point where you say, well, I have no more left, so I'll only be able to administer to phase 1A now, and so on. And what that does is it allows, once again, a better matching and leads to lower number of unused doses at the end of a day or at the end of a week. It does increase some information needs, which means you do need to have a scheduling or some sort of a pre-registration system in place. The other part which is important to keep in mind about the pre-registration system is that when demand is uncertain, and we also are seeing some issues about supply being uncertain, especially what we've heard from Pfizer, BioNTech, and in particular AstraZeneca in the last few days for Europe. So when you have supply uncertainty and demand uncertainty, it is in our interest to at least control the parts that we can control the best. And we can control demand uncertainty to some degree by a pre-registration system, and that will allow us to match, once again, match them better. The fourth point I want to talk about is the structure of distribution. And there has been a lot of debate about, should clinics be getting doses allocated based on population and number of people in a given tier, or should it be based on how much they have used in the last week or the last few days, and should the allocation start reflecting their actual usage? So the difference between what we call as push allocation versus pull allocation. And again, we don't have a clear answer on this. I'll come to this in a second. And then the last point is what types of points of dispensing to use. Should it be only existing sites? So we've seen the India program focusing largely on existing sites, which by existing sites, I mean existing clinics and primary health centers where people go for routine healthcare. Israel is similar. But in some other countries and in some states in the US, we are seeing that the use of mass vaccination sites is growing. So again, it creates a policy question for some of the people as to what is the right way to approach this. So one interesting thing we've seen in how the structure has changed is most countries had a vaccine distribution system that looked like what I've put on the left side of this graphic, which is an outward tree, where things start branching out at every stage. But what we've seen being used for the current rollout, at least so far, is something that looks like the picture on the right, which is it doesn't branch out too much up to a certain level, and thereafter it branches only towards a very terminal point of the chain do we see branching. And that shift means that some new rules and new standard operating procedures have to be put in place, because people were used to going through a certain system, and now we are doing more direct in some cases. We are doing less or somewhat more linear distribution models in some cases, and we've seen that in at least one or two countries that this shift led to some initial glitches in how flow was happening in logistics. Then back to this issue of when do we switch from push to pull, push being we send doses to a clinic, pull being the clinic or the vaccination site starts sending how much it needs. And I mean, in theory, we would say we should switch to pull when the system has reached an equilibrium state, which means the first few weeks have passed, the vaccination sites have some idea of, on an average, how many people do they get each day. But the timing of when we reach an equilibrium state remains undetermined. And what do you even call an equilibrium state in a system where you have multiple tiers and then you are going sequentially from one tier to the other? Then we have some pending questions which we don't have clear answers, but I think similar to what Ron was describing about agility, I think this is required not just at the terminal point where you're administering the vaccine, but also at additional layers in the system. So someone at the subnational level should be able to, should have the degrees of freedom to make decisions. And we cannot create criteria that are extremely stringent because we are working in an environment where things will change. And that hasn't always been easy in multi-level government systems. Then is this issue of having large sites versus continuing with existing primary healthcare apparatus. And what we've seen is that large sites create an additional, in addition to increasing throughput, they also create an additional benefit, which is by pooling demand into one location, the overall uncertainty in demand becomes lesser. So the key bottleneck resource, which is the vaccinator, the person who's administering the vaccine, is utilized more of the time, and they are not idle, as would be the case if the total demand was fragmented into multiple smaller clinics. And because of the nature of demand uncertainty, sometimes a vaccinator is waiting because the scheduled person doesn't come, or the total number of people they were anticipating did not show up. But then the challenge becomes, this is theoretical that you have higher throughput and you have better demand pooling. But to achieve those benefits, the operational design of the large sites needs to be very well thought through. And we have seen examples. I'm showing two pictures here, one from Berlin, one from Singapore, where operational designs have been thought through very carefully. But that doesn't mean that all of these mass vaccination sites that we are seeing, including large sports arenas and stadiums, are beneficial, because they are not implementing a good operational design. So that's another part, I think, which is a key consideration. And then the last thing I wanted to mention was that there are, I'm using an illustrative list, but there are a number of technology companies who are able to use advanced technology and solve many different functional problems in vaccine rollout, whether it is forecasting clinic demand and matching it to supply, or if a country wants to use biometric identification. We also have issues around, can we get the right insurance and using Internet of Things or sensors for geolocation and understanding where the product is, etc. So lots of technology can go in. Once again, it's hard to do this by selecting a vendor. Government finds it hard to select a vendor when they're in the middle of a large-scale rollout. So I think where government policy bodies have to think about is how to create a structure so that it's not asking a company to act as a vendor and do a contract, but rather some kind of a blueprint in which they can plug in with their own technology solution as and when they feel it's fit. The last thing I want to mention is that in all of this, even when a country is thinking about its own vaccine deployment strategy, we cannot forget that we require equitable global distribution. So even if I am designing the system for the UK or a country in the EU or in the US, we have to keep in mind that we will benefit from equitably distributing vaccines that we have. And this sometimes has implications for how you design the system, which means you may have to sometimes forego being able to get a lot of doses too quickly, and work with a slightly more realistic throughput expectation than just assuming that you can do this very, very quickly, because the total manufacturing capacity is limited. Again, we ought to work harder to increase manufacturing capacity. That goes without saying. I'll stop there. Back to you, Piroshka.
Thank you very much, Prashant. You have put more ideas and meat, so to speak, on the process, on the system, on the logistics. And you also highlighted what we haven't discussed, and it's not very often discussed, the role of technological companies, private companies in helping this vaccination drive. And now we turn to our third speaker, our very own Professor Olivier Waters from the LSE. Olivier, the floor is yours.
Thank you, Piroshka. Let me just go ahead and share my screen. So here we go. Great. Well, thank you thanks for having me on this webinar. And yeah, great presentations. Really interesting, like Prashant said, to hear Ron's information coming out of Israel, the efforts to get the vaccine out as quickly as possible. Prashant's presentation as well, talking about the logistical issues. Prashant ended on a perfect note about global equitable access, which is what I'm going to focus on here in this effort to vaccinate the whole world. So I'm going to take a slightly different perspective from the two presenters and look more globally at issues. And I'm going to do this in about 10 minutes. So I'm going to focus on 3 key points that I want to impress upon you. So the first is, while a lot of countries are looking to Israel, to United Arab Emirates, UK for lessons about how they can more efficiently deploy vaccines, for a lot of countries on Earth, that's a second order problem, right? Most countries on Earth now are looking to see how can they access any doses of vaccines, can they secure vaccines. And so what I've put here are some data from Duke University. I'm sure many in the audience will have heard about all these deals that have been struck between various governments and companies, these bilateral deals. And so the countries here are grouped by income category. On the left-hand side, high-income countries. So this is the World Bank's definition of a high-income country based on GDP. High-income countries, home to about 15% of the global population, but these countries have secured 4.2 billion doses as of early January. In the middle, you see upper middle income, lower middle income countries, and low income countries, far fewer doses. So this imbalance makes it really difficult to achieve global equitable distribution. And it's not the first time we see a similar picture. Back in 2009, when the pandemic, the swine flu pandemic emerged, very similar picture where rich countries were buying up a lot of the doses of vaccines. Back then, it turned out that the virus wasn't quite as lethal as we had initially feared. But again, here we're seeing a similar picture. Now, one thing that's different here is that in response to the last pandemic, the swine flu pandemic, in an attempt to avoid a repeat, the World Health Organization, together with Gavi and CEPI, 2 other international organizations, have set up a global entity called COVAX. It's the bar on the right here, to try to promote global access to vaccines, to try to make sure that all countries have access to some doses so that they can vaccinate their healthcare professionals, their high-risk patients. Now you can see here, despite these efforts, there is a vast imbalance, and it really threatens the global allocation of vaccines. And before I go on to talk about some ways we might be able to ameliorate the situation, I think it's worth stressing that these nationalistic tendencies are quite short-sighted, because as Piroshka, you started off talking at the beginning, we're now seeing mutations emerge. We're seeing new virus mutations that might undermine the efficacy of vaccines. We also know that our economies are intertwined, and there's flow of people across borders. It's very difficult to contain the pandemic in any given country unless we really try to tackle or stem the global tide. And so what can we do about this? Well, one thing that a lot of commentators have mentioned, and I would agree with, we need to provide more funding and political support for COVAX. At this stage in the pandemic, it's probably the best vehicle for achieving global equitable access. And in addition to promoting COVAX, we need to expand production capacity, and this is something that Prashant mentioned in his talk. So that, to me, is really the rate limiting step here. If we had more production, if we had more doses available, we'd have enough to go around. We wouldn't be quite as worried about where countries lie in the queue, if they're striking these deals or not, if we had enough doses for everyone. Now, obviously we don't. It's a very unique situation we find ourselves in. If we need to vaccinate 5 to 7 billion people, let's say we need 2 doses per person, we're talking 10 to 14 billion doses of vaccines. That's an unprecedented challenge. So obviously the production challenge here is immense. Not only that, and I'll get to the slide, the data points here in a second, but not only are we facing an unprecedented challenge, some of the vaccines from leading manufacturers, or some of the leading vaccine candidates rather, like the Pfizer vaccine, the Moderna vaccine, they rely on brand new technologies. Right? These are mRNA vaccines. They don't have any existing mRNA vaccines. So there isn't an existing production capacity. There isn't to the same extent perhaps as some other vaccines. And then of course, there is this immense production challenge is putting pressure on supply chain for basic inputs like vials, syringes, adjuvants. So again, very tricky situation we find ourselves in. I just want to flag, so I picked here a handful of leading candidates. Some of these have been authorized for emergency use. Some are in late stages of clinical development, so phase 3 clinical testing. And you can see here the estimated production capacity for some of these. Now, I flagged the ones here, the red square, or sorry, the rectangle. These are the ones where the companies have set targets for 2021 of 1 billion doses or more. But I should say, as we heard from Prashant, that some of these developers are already struggling a bit to meet demand. Today, only as recently as today, we saw AstraZeneca is having trouble meeting orders. Pfizer, BioNTech, same thing. So again, it's difficult to know if we'll meet these targets. And again, some of these vaccines haven't been approved yet. But with that said, that's why it's so important to try to expand production capacity so that we can alleviate some of these supply constraints. Again, scarce supply is the rate determining step at this stage. So one thing I think that can be done is for funders of these projects. So a lot of these vaccine manufacturers benefited heavily from public funding during the development of these vaccines. The US government, the EU member states, CEPI, Gates Foundation, they poured money into these projects. And with that funding, you would think that the funders could leverage that to build in licensing conditions, access agreements into these contracts, which I know CEPI does to some extent. To try to encourage and promote these manufacturers to share their technologies more widely, to license their technologies to partners in other countries, share the know-how, have deep technology transfer. And indeed, we have seen that with AstraZeneca and Oxford. So Oxford, when they teamed up with AstraZeneca, made this one of the requirements. So AstraZeneca has teamed up with Fiocruz in Brazil, the Serum Institute in India, partners in Thailand and other countries to try to expand capacity. And in fact, that's in part why you see it at the top of this list. It's got 3 billion doses that it's expecting to produce this year with its partners. So before I move to the final point, I just want to flag or map on the point I raised in the previous slide. Here, you can see that for a number of these vaccines, between 80 and 100% of doses have already been bought up by rich countries, by high-income countries. Right. So again, that's going to make it difficult. So BioNTech, Pfizer, they have 2 billion doses they're hoping to produce this year. 80% have already been bought up. I should say also that these numbers are from the Duke University website again. They might not be exact because not all deals are publicized or made publicly available, but these figures should be pretty close to the true ones. And final point before I move to the next slide, some of these developers have struck agreements with COVAX. So they've said we will reserve some supply for low and middle income countries. But even here, devil's in the detail, because while we have struck agreements, some of these are quite small in size. So Pfizer and BioNTech, for example, they've said, yes, we will supply COVAX, but we're only going to supply up to 40 million doses, which is a drop in the bucket, obviously, in terms of what COVAX needs to meet its mission. The third and final point, looking ahead now to 2021, we have several vaccines that have been authorized or approved for human use. Probably many more or several more are likely to be authorized this year. There's something like 69 vaccines in clinical development, 20 odd vaccines in phase 3 trials. So it's quite likely we're going to have new authorizations quite soon. And with new vaccines, we can start to think, well, are some of these more suitable for deployment in some settings versus others? So I've just put 2 characteristics here worth mentioning. First, number of doses. This makes quite a difference in terms of, and this follows on nicely from Prashant and Ron's talks. The digital system in Israel and the apps that it's allowed people to be notified that they need a vaccine, recalled for their second dose at the right time. If you have tiers, priority groups, you need to go down the groups sequentially. You can try to simplify it as they've done in Israel, but still, this is quite logistically and administratively complex. If you have a 1-dose vaccine, and Johnson & Johnson, I think, are expected to announce the results next week, that could alleviate some of these constraints, particularly in resource-poor countries that might not be able to administer that kind of a system or a vaccination program very easily. And even in rich countries, this could be beneficial. And something else I think a lot of us have heard about, the storage requirements during transport. So several of the leading vaccine candidates have to be kept deep frozen, right? This is Moderna, minus 20 degrees, Pfizer, BioNTech, minus 70. Even in well-resourced countries, that's very difficult to achieve, right? thinking of how to get these vaccines to hard to reach population in more remote parts of the country. You can use some of the logistics company that Prashant mentioned, but again, it's still quite complex, let alone in resource constrained settings. So there are other vaccines that are in late stages of development or approved or authorized rather that have can be kept just in a regular fridge, 2 to 8 degrees Celsius. That includes AstraZeneca and Oxford's vaccine. And in fact, there's even one, Sinovac, which can be kept at room temp. So again, thinking ahead, we can start to look at, well, are some of these more suitable for certain environments? This can inform or help inform COVAX allocation decisions and also procurement decisions by individual governments. So I think I'll stop there. I just want to reiterate the 3 key points. I think, one, we need to think about global access. Deployment is incredibly important, but global access is as important. And 2, we need to expand production capacity. It's a rate determining step. And 3, looking at the 2021, we can start to see which vaccines might be more or less suitable in different environments. Thank you.
Thank you very, very much, Olivier. That was a fantastic compliment to what we have heard from the 2 other speakers on the points that you stressed at the end. So I'm not going to repeat it and sort of opening up the global access issue in general and suitability. So we have a number of questions to our panelists. Let's start rolling those out. The first question is coming from Astana Ice Gershbeck. And she's asking the question that comes very, very often up, this issue of 1 dosage versus 2 dosages and the decision around this. Now, Israel, as I understand it, has decided to stick to the 2 dosage policy. So I'd like to ask Ron first why you decided to do that and with the timetable that you have. And I can attest that indeed, once you get the first vaccination, you get the second appointment as well immediately, and totally on the dot. So why you have decided to do that, and if other panelists colleagues would like to come in on the pros and cons of that question, Ran.
Thank you. First of all, it's worthwhile mentioning that there was a debate here about this question, and there are reasons to look at each one of these different approaches has its own merits, and the decision to make eventually is setting specific. It depends on many issues which are very specific in different countries and in different points in time. So the issues such as the available vaccine and the rapidity in which you expect to receive more vaccines is something that would make a true impact on what your decision could be. The opinion of the leading scientific authorities in your countries on what would be expected to be the effects of 1 dose for a longer term versus 2 is also of great importance, as well as how dire the condition is in terms of the dissemination of the disease, which means how pressed you are to get a higher number of the population covered. So all of these are, I think, relevant things to consider. In Israel, the decision was fairly straightforward. We knew we had enough vaccines in stock in the first few installments to properly vaccinate our population at risk, all of it, with 2 doses. So if you can do that, you probably should, because especially for the elderly and those that their immune system is not the strongest, you would have reasons to believe that they would benefit from a booster dose that would have perhaps potentially increase their antibody titer and make them more resistant to the higher dose of the higher viral load if they encounter such. Another issue to take into account is we see more and more strains which drift in different levels from the strain that was used in the vaccine. One could theoretically think that a second dose that would boost and therefore increase the antibody titer might be able potentially to more effectively deal with drifted strains that are slightly or more substantially different than the one that is included within the vaccine. And so when this becomes an issue, I think that's something that you at least need to consider, although the evidence to that is not existent. Okay, so this is a theoretical construct, not something that we know for sure. And finally, at the end of the day, the trial that we have and the data that we have is for a 2-dose regimen. That's what we know for sure. And that's what we have from the Pfizer and Moderna and the other from the clinical trials. We know what we can expect from a 2-dose regimen. We're not sure what would happen if we only give one. So therefore, the decision, as I said at the beginning, there's not right or wrong here. I think this is a setting-specific decision. And according to the amount of vaccines that you have and the ideas that your leading scientists have, that's how you make your choice.
Okay, thank you. Prashant, I saw your hand up.
Yeah, I was going to say one quick thing in addition to what Ran said. So, I mean, one is the epidemiological and clinical issue. The other is a somewhat tactical supply issue. And we also see components of human behavior that get embedded in this. So examples are, we've seen in the US, but also in other places where the idea of reserving stock for the second dose is something that happens at multiple locations. So the government is holding a second dose, the state is holding a second dose, and the clinic is holding a second dose because everyone is uncertain about whether they will get supplies or not. And that is what leads to, I mean, we see states in the US which have only used 27% of the total allocated supply. The remaining 60-some% is sitting in a freezer, chilling somewhere. And that's because of the second dose issue. And so I think one is the clinical and epidemiological aspect where I agree with Rand that we should stick to what we learned from the clinical trial, but we also have to resolve this over buffering argument that's happening.
It's very interesting. Thank you very much. Olivier, can I ask you sort of, can this sort of making the vaccine more equitably distributed in the world, this 1 dosage, 2 doses, can it help? We know also that in Britain, the debate is for kind of pushing ahead with 1 dosage and for a quick coverage, even within the country. What's your view?
Sorry, I don't think I quite understand. So linking it to equitable distribution. Sorry, could you? Sorry, I think you missed the first part of the question.
Yeah, no, just I was wondering that if you were to move away from the 2 dosage, then even though you have data for that, whether that would help.
I see what you mean. Alleviate some of possibly. It's not an issue I can speak about too much. Whether it should be 1, 2 dose. I think Ron is much better placed to answer that. Potentially, I think it would depend on how long you wait, because they are still being administered a second dose. It's just about how long you wait between doses. Depending on allocation systems, that could alleviate some of these constraints. But again, I think it's a hard issue. I don't know I don't want to comment on which approach is preferable, since that's more of an epidemiological and for clinical trialists to decide, vaccinologists. So.
Since I have you, there is a question related, which came actually by email from a colleague, and the question is the price of the vaccine. So is the price related to the investment made with governments and private companies, or how pricing is determined, and whether that is also a factor here on availability?
Yeah, it's a really interesting question. I don't think we have a good answer yet about what's driving the different prices. So prices have started to emerge. Several companies have started to reveal the prices they're charging different countries of different income levels. So we have price tags for the AstraZeneca Oxford vaccine, Pfizer BioNTech, Moderna, a number of others. But we have we don't have so many data points. It's hard to say definitively whether, let's say, public funding is linked to price levels. What I can tell you is that some of the manufacturers that have accepted a lot of funding have quite low price tags. So AstraZeneca Oxford's a good example. They received substantial public funding, and they have promised to price their vaccine at at cost, at least during the acute phase of the pandemic. So they're charging between $2 and $3 a dose. Johnson & Johnson, another one that's benefited quite a bit from public funding, they're coming in at about $10 per dose, and that's a single dose vaccine. So that's $10 per course of therapy or treatments. Others like Pfizer and BioNTech, they're charging quite a bit more, and they have taken far less funding. They were one of the few companies, the leading companies, that accepted no funding from the US government. And indeed, you see a higher price tag for their vaccine as a result, or potentially as a result. But it is really hard to say what's driving prices because it's not just about public funding. It's also about the technology, right? There could be differences in research and development costs, manufacturing costs for an mRNA vaccine versus a replicating viral vector vaccine, and other strategies, sort of how this fits into the broader profit-seeking strategies of different companies. So it's hard to say that one factor is why you see a low or high price. I think it's quite a bit that might be driving the variation. Yeah.
Okay, thank you very much. We have a question from Daniel Gross, a dear colleague from SEBS, which is a lead think tank based in Brussels. The question is directly to Olivier. You've showed that the total supply likely to be available for the entire year in terms of vaccination in Israel. Is there any source with information of the supply over time? Do you have ahead by months or quarters, sort of how?
That's a great question.
Data availability.
That's a great question. So I don't know. I haven't seen the data myself. If anyone has it, it would probably be CEPI, the Coalition for Epidemic Preparedness Innovations. Gavi might be collecting this because I know they've done landscape analysis to look at manufacturing capacity globally. And I would imagine, I actually did recently see figures for COVAX or vaccines that have agreements with COVAX, and they have projected by which point in time this year they will be receiving different allotments of doses. But for individual manufacturing on a month or quarterly basis, I don't know if that's available. Again, the place to look would be CEPI or Gavi, I think, unless companies themselves have volunteered this information.
Okay, thank you very much. We have a question, and perhaps I would direct it to Ran, about the immunity of people over 80 plus. Is the vaccine as effective in this age group as elsewhere? It is a question from Antonio Costa.
Thank you for this question. As I said, we are now in the final stages of analyzing a huge amount of retrospective data that would hopefully allow us to not only be able to tease out true vaccine effectiveness after dealing with all of the methodological challenges, but also be able to view this in different population subgroups and be able to answer some of these questions that were more difficult to answer in the lower end clinical trials. So this is work in progress, and I don't expect it to take too much time before we can finish that, put it in a publication format and make it public.
Thank you very much. Since I have you, Ben Grazda from our school's Department of Government, student there, thanking you all for the wonderful discussion. And the question is to you, Ran, again, regarding this disinformation that you mentioned at the beginning and how proactively you fought that. The question is where it was exactly coming and how it was spread. Was it just a cultural element that you mentioned, and how did you fight it? There were some, maybe he's not saying, but there was some news that there was an agreement with Facebook, for example, to take down blatantly misinformative pages, for example. Ran?
Yes, so that's an excellent question. Thank you. I will give you two examples. I think one we can look at social media as one key source of a deluge of really interesting types of misinformation and disinformation. I think we are all more used to that by now. I mean, we've seen it in other walks of life, and we have all developed ways to deal with differentiating truth from fiction. And there are ways of doing that as well in social media by what we mainly try to do is to maintain credible sources of data that are continuously updated by people that public trusts and knows well, that continuously disseminate evidence-driven, data-backed facts that are the best way to confront some of that fiction. Again, there's the fringes that you will never be able to reach, but I think that the vast majority of the public is interested in the facts and is willing to accept them as such if they are driven by numbers rather than by opinions. So this is one way. The other thing that's worthwhile mentioning was the directed, I would say, a confrontation on the ultra-Orthodox streets, where people who had, I do still to this day don't know what was to achieve by that, but they had posters with horrible misinformation, warning in the language that is appealing to the ultra-Orthodox community, telling them, don't dare taking the lies of don't dare taking the vaccines, they will make you sterile, they are dangerous, etc., everything that we know. And so the way to really confront that was through local leaders and community leaders and people that in those communities, there's a very hierarchical approach to disseminating knowledge. And what we've done is we went to the chief leaders of each one of these communities, and through direct talks with them have used their communication channels to deliver credible information. Clalit, for one, has created journals that were directed for this subpopulation with both interviews with decision makers in that public, as well as with hard facts backed by information. I myself have given numerous briefings to communication channels that were specifically looking at that sub-specific population and working with their leaders. And so I think all of that together helped us cope with it.
Yeah, thank you very much. A question to Prashant. You mentioned the particular difficulties, challenges when it comes to multi-level governments and decisions and safety built in at every single level, leading to tremendous waste. As you see this problem, particularly in the US, what is your main recommendation to this type of multi-level governments? Sort of, what should be decided by sub-level governments, what national, state, and federal? Is there any easy solution, or we just will go through learning by doing and end up with a lot of waste?
Yeah, I don't know if I have. Yeah, it's probably a topic of multiple PhD theses, Piroshka, but I think what I can say based on at least conversations with colleagues in 2 or 3 countries who are running large programs is the following: that the decisions about supply, manufacture contracting, logistics, infrastructure investments have to be made by the central government, and decisions which are about the demand-related processes, such as what would a community prefer, a small vaccination clinic or a stadium? If yes, where should that stadium be located? Those are decisions which are based on knowledge which is tacit and not always codifiable to be sent to the central planning agency. And so those are decisions where the locus is better suited to be at the local government level. But again, we have an ongoing debate on this issue, here in the US, but also in other countries as to who decides what type of clinics to create and so on. So again, very important question. I don't know if I have the answers to it. We'd love to also hear Ran's viewpoint on this.
Ran?
Could you just repeat briefly the point that you want me to relate to?
It's this multi-level. I don't know whether in Israel that's a kind of a challenge, sort of multi-level government when you have the local community, municipal, and higher up. It seems to me that in Israel the decision making was quite centralized, but it's not the case in other countries. So the experience in Israel.
So in my talk, I've mentioned the fact that one of the structural benefits that helped Israel roll out its vaccination campaign the way it did was both the fact that it is a small country in terms of population, but also geographically condensed. And I would add to that there's no need for this multi-layered approach that has to be done in countries where they have a federal level, a country level, a local level, etc. you know, the whole country is so condensed in that term as well, that there was very few degrees of separation between the airplane coming down with the shipment of vaccines, a central hub where all of it is being contained, and then moving it almost directly to the target points, because the worst that you can do is be perhaps 3 hours driving away. So that, you know, that makes many of the logistical issues, as well as the political and the different levels of hierarchy and all of that complexity, pretty much be gone, because all of this campaign was run from the central government and the HMOs, which are all country level. So that made things a little bit easier.
Can I ask you like a question about the importance of the continued importance of what is called this non-pharmaceutical interventions, the masks and the hand washing and the social distancing? It seems to me that it's easy to, the vaccine has a risk that people get overconfident. And when you walk on the streets of Tel Aviv, you see much less mask wearing than just a week before or 2 weeks ago. So how you keep that? That seems to be also an important challenge for communication at this stage.
Yeah, I think we're in the midst of, there's generally a pandemic fatigue that is a problem in every country, but those countries that are in a prolonged lockdown and economical daily issues, I think that is a bigger problem. Maintaining public vigilance is really a big challenge, and they're willing to participate in the joint effort of a lockdown, of social distancing, of mask wearing, and that is indeed an issue. Now, regarding the vaccination, it is a critical component of the vaccination campaign to educate people about when they are not protected. And we have made every effort to tell everyone, until you get the second dose and 7 days later, please don't think you're protected. Granny, don't go and visit your grandchildren and don't put them at home and start hugging them. It's far too early. I would add on this and say that even if 7 days have elapsed from your second dose, and the conditions right now in your area are of a massive dissemination of disease in the community, that's not a good time to hug your grandchild just yet. The vaccine failures are a fact. We know even in the clinical trials, they're 5%. We can only imagine what they would be in real world settings. And so this is at this point not a worthwhile risk to take, and we need to communicate it and communicate it better.
Thank you very much. A question on the global distribution, probably to Olivier. Is there, if some countries are oversupplied, is there a chance that there would be a redistribution over time? There is a Norway commitment, for example, that Avi Manger is citing.
Yeah, I think that's a step in the right direction, absolutely. So Norway is quite unique in that it said that at the same time as it's vaccinating its own people, alongside that it's going to be distributing doses to other countries. So they're doing it at the same time in parallel, which is really in line with the mission of COVAX, which is all countries need to vaccinate at least their priority groups, healthcare workers, before other members of the population are vaccinated. So Norway's going in that direction. That's great. Again, I guess it's just left to be seen whether enough countries sign up for that kind of, or adhere to that kind of a principle. If everyone ends up vaccinating their populations first, and once that's done, giving any excess doses to other countries, that could be problematic. So again, it's just going to depend a bit on when these doses are secured for other countries. There have been estimates saying that most countries, most middle and low income countries, are not going to have widespread access until 2022 at the earliest. There have been estimates, and those have tried to account for these kind of conditions. So again, it waits to be seen. I applaud Norway for going down that route, though. It's a great precedent.
Thank you. And we are actually getting, after a very intense, more than an hour discussion, we are getting to the end of our wonderful panel. Maybe a final question. Let's be positive here. We want to be and want to ask each one of you, what will be when you will feel that we have succeeded, when the effort has paid off? What will be the clear sign of success that we are on the right path to tackle it? nationally and also globally. So maybe I ask Ran first, and then the country, and then we open up globally.
So
when will you be happy, Ran?
When will I be happy? When I will take a long, good night's sleep.
Yes.
That would be great. Traveling abroad would also be nice to do again, but that's personally speaking. Now, in seriously,
yes.
I would be happy when the risk of hospitals reaching a point of insufficiency would be completely made non-feasible through a strong, effective vaccination campaign that would allow us to treat this disease as just another winter illness that would inflict some and would make some sick, but on a population level would not make health systems and countries collapse, at which point we can put it behind us, go back in our almost normal lives, make our economies reignite, and start fixing all of the horrible damages that this disease, but also the efforts we made to contain it, the very deep scratches it left in the fabric of society. When that will heal, then I will be happy.
Very good. Prashant?
Yeah, two things. So one is having enough global coverage to not just vaccines, but a full range of therapeutic and preventive tools, which would include therapeutic options that we would need for localized outbreaks, or even for those who progress to severe disease despite getting vaccinated. So therapeutic and vaccine tool high coverage. That would be one way I would call things to be successful. But the second and more oftentimes forgotten piece will be that we don't let this opportunity pass in terms of building sustainable manufacturing capacity, building sustainable collaborative structures for the next pathogen. And whether it is a variant or a completely new novel pathogen that comes our way, and this is too strong a reminder for us to forget that. So that will make me happy if at the end of this we do create that infrastructure.
Thank you. And finally, Olivier.
Yeah, I think both speakers have made great points. I think I fully second what Prashant just said. I think one, global coverage so we can stem the pandemic, so we can all across the globe return to some sense of normalcy. And I think what Prashant touched on at the end is really important, that we learn something from this. There will be a surprise pathogen at some point in the future, and hopefully we put up systems now and we think ahead and we look ahead to the future, so we don't find ourselves caught by surprise like this again. So yeah. Excellent.
I'm so happy that we touched upon the preventative aspect of this, and learning quickly and be prepared for any such eventuality. So this is the end of it. I will not pretend to try to summarize, which has been a truly enlightening discussion by each and one of you. It was great to learn from the experience of Israel, also the challenges, but the positive things that comes out, and what we can learn about the system itself, the healthcare system, the digitalization that many of you actually pressed as an important to have the digital infrastructure in place. The simplicity of prioritization, even though of course you hit probably the most riskiest person, but the simplicity is so important. We discussed the process, for example, the logistics. It has to be tight, but also flexible. At the end of the day, Israel releases its tight release the extra supply that otherwise would be going to waste. So flexibility is also important in a tight logistics. We talked about technology overall, and role of the private sector that we sometimes forget in the vaccination strategy as well. Communication, fighting disinformation, fighting vaccine hesitancy for cultural reasons or other, and finally also the equitable distribution, as has been stressed. There are channels to make even with national emergency channels to have a more equitable distribution and expand capacity. Thank you all very much, Professor Rancière, Professor Yadav, Professor Waters. This has been fascinating. We are grateful. We let you go to continue to save the world in a very literal sense. We are grateful to you and wish you all the success. Thank you.